Brilliant, excellent. Thank you very much. Thank you for giving me this opportunity to come and talk about it. I'm going to sort of, be really, really basic. I think it's ABC of Eclampsia. It's all in the name. Yeah. And actually, what I want to, okay. So I'm just going to touch on that basically. So Sue has already been spoken about it. I just want to say that, if you look at it, 9 women, that's about 4% of the women actually, um, died because of preeclampsia in 2019 to 2021. That's the Embrace Maternal Maternity report. And this is the maternal mortality by cause in the Embrace UK 2019 to 21 and 2020 to 2022. And if you look at it, preeclampsia is here. And it is 0.35 in the recent one, which is from 2020 to 2022, and it was 0.44 before. So if you look at this is where it is. So, not a negligible change in it, but, it's still sort of out there. What's really good, what Sue has actually pointed out as well, is it's decreased from what it is, but it's still an issue. It's not something that we can, forget about. So I'm just going to be talking about what it is, what causes it, what are the physical examination associated with the diagnosis, what are the investigations and the management. Yeah. So really, what is eclampsia? Actually, literally, what it means is an electric bolt out of blue. It's driven from a word in Greek language. And that's what it means literally, but actually it describes a type of convulsion or fit, which is all involuntary contraction of muscles that pregnant women can experience, usually from anytime from 20 weeks or after the birth, usually within the first 48 hours. Now, there are always sort of, exceptions, and there are exceptions. It can happen before 20 or after 48 hours as well. But this is what the definition is. Eclampsia is a severe complication of preeclampsia, and it actually affects both mom and the fetus, and the incidence is 0.3%. Now, various theories are there, and Sue's actually already touched on some, but what it's important to know is most of it, it's a continuation of preeclampsia. So you would have, the factors, the placental ischemia, you'll have endothelial dysfunction that's been caused by all the remodeling that, Sue has been talking about, the syncytial trophoblasts, the cytotrophoblasts. They have not invaded the placenta as much as there was a constriction, there's reduced placental flow that releases then sort of causes oxidative stress that leads to endothelial dysfunction that can actually cause fibroid necrosis in the microvascular structure of the brain. It can also cause impaired myogenic tone and cerebral hyperperfusion that can cause cerebral edema. And actually, the disruption of the neural microenvironment can actually cause seizures. And if we move on, this is the BBB stands for blood-brain barrier. So if you look on the left-hand side, this is the intact blood-brain barrier, where you have the endothelial cells, the tight junctions, there are surrounding structures, basement membrane and astrocytes. These are just some cells in the brain. But when you look at the damaged blood-brain barrier, you see how all these cells are broken and the cytokines can go in and out quite easily. And that is what actually, is thought to be one of the reasons why eclampsia does occur. It also, this is just another form that is showing you the continuation. Predisposing factors to preeclampsia cause abnormal placentation, hypoperfusion, because that is the one that actually releases an oxidative damage and ischemia of the placenta. That actually leads to diffuse endothelial damage, systemic hypertension, increased cerebrovascular resistance that will cause vasospasm or contraction in the cerebrovasculature, cerebral edema, and symptoms of seizures. what are the warning signs? What do I want to know? So if I'm a clinician and if I'm a midwife, what do I want to know about this? So how do I know somebody's having this? So, initially I've established the risk factors, the moderate risk factor and high risk factor for eclampsia, for pre-eclampsia, and that can actually go on to have, those women can have eclampsia. But eclampsia can occur without overt pre-eclampsia. It's important to keep that in mind. What are the possible warning signs of eclampsia? They have severe headache, they have abdominal pain, they have nausea, vomiting, they're not able to pass urine, they have difficulty breathing, they've got swelling, and they've got blurred vision. Now, some of the things like swelling of the hand, face, or ankle, or nausea are features of pregnancy. And that's where it is so important to actually ask the woman and take her history. All this is that I'm saying has to be taken in conjunction with a whole history, previous history. And these are what I'm telling you about the signs and symptoms here. These are the sort of things that are common, but they are atypical cases as well. So we need to have high index of suspicion. But usually when we talk about what is general, what is common. What is the most important thing if you have somebody with eclampsia, somebody who's fitting, a pregnant woman who's fitting? First of all, you call for help. And who do you think you'll be calling for help? So if this is a patient who's fitting, there's an emergency buzzer, you are the midwife, and you go in that room and you saw this woman, and your midwifery colleague says she's being induced for severe hypertension, and, let's say she's delivered, and she's having a fit. What are you going to do? You're going to call for help, yeah? Because she's called emergency buzzer, you've gone in, you either will send somebody or go and say, can you call for 2222, come to this room, there's obstetric emergency, eclamptic fit, and you will get obstetrician, you'll get neonatologist, you'll get anesthetist, yeah? And what we'll do is you'll go in, you'll make sure she's on left lateral, airway secured. What's going to be really harmful to her life first if she stops breathing, yeah? So it's really, really important. It's eclampsia. You do the ABC, do the airway, make sure that the airway is patent, make sure she's breathing. If she's fitting, she can still breathe. You can put her on lap lateral, make sure her tongue is out, put some oxygen on. You've done A, you've done B, then you go to C. When you go to C, you will put 2 intravenous IV access. Yeah, you'll make sure you'll do a blood pressure at that time. When you're doing intravenous access, that's the time for you to do the bloods. The bloods you will be sending will be full blood count to look for hemoglobin and to look for platelets. Why would you want to look for hemoglobin? You would want to look for hemoglobin to see whether she's got any hemolysis. Why are you interested in hemolysis? Because it's a complication of severe preeclampsia. It can be a complication for eclampsia as well. It could predispose, it can precede eclampsia, or it can follow eclampsia. So that's why it's important for you to do a hemoglobin when you do a full blood count. And the platelets you'll be looking for, whether they're low or not, because HELP also have low platelets. Also in severe eclampsia, you have low platelets. So that's what you'll be looking out for full blood count. You'll also do urea and electrolytes in this patient. And what are you looking for this? You're looking for creatinine, yeah? So you need to know, because preeclampsia and eclampsia is a multi-system disorder, yeah, it is important for you to know whether it's affected the kidneys. Has it affected the kidneys? What is the creatinine? And why is it important to know that? Well, what's the creatinine? Because the drug that we give for treatment, which is a magnesium sulfate, 90% of its excretion is through kidneys. You need to know what it is, because if you're going to put you on this, you're going to, you don't know, you don't have the bloods. Let's see, she's just come in and, she's having this fit. You would actually put IV access, take the blood, send them off, put magnesium sulfate, and then have, if she's not delivered, do a delivery plan and evaluate everything. It's important to know creatinine, because you may have to change the dose of magnesium sulfate. If it's more than 150 creatinine, we tend to stop there. If it's more than 100, we tend to half it. Yeah, so it's really important to actually know what that is. Then you also will do liver function test. Liver function test, you will need to know elevated liver enzymes. Yeah, what are the transaminases doing? What is the gamma GT doing? How extensive is this damage? So she's, her BBB, her blood-brain barrier, has been affected. This lady is having fit. She's a multi-system disorder. Is the liver affected as well? That's what you're going to be looking at in the liver function test. And you'll do clotting as well, because what happens? Where does the clotting? It's a synthetic function of the liver. So liver will not only be affected by the liver function test, you'll only also be able to find out what the clotting is as well. And DIC is one of the complications of severe preeclampsia. So you will look at that as well. We do tend to send a peripheral film to look if there are broken cells in it, aneupcytosis, poikilocytosis. We do a retic count. Retic count are the young blood cells. Yeah. So if we do a retic count, what that tells us is there's hemolysis going on, and the body is actually trying to build more blood cells. So the retic count would be high. And we'll do a LDH. LDH is an oxidative substance. It comes out when the blood cells are broken. So these are the sort of things you'll send for. Now, how many things I have said? Quite a few things. Now, if somebody's sitting there, you're not gonna, that's why before you do anything, you need help. You need people there. Yeah, it's a very different situation. You can't do all these things. One will be airway, one will be sorting breathing, one will be doing the circulation. You have to stabilize the mom first. If there's a massive bradycardia, don't go rushing to the theater. Mom has to be stabilized first. And when mom is stabilized, then we can talk about delivery plan and we can evaluate everything. So it's really, really important. I think one of the most important things is that, when we have patients like this, when we have severe preeclampsia, first of all, let's not come to this stage. Start, if you think somebody's got severe preeclampsia, start a magnesium sulfate, because that actually more than halves the risk of having, eclamptic fit. So, and make sure that we inform our anesthetist, like, look, we've got a severe preeclamptic here. She could have a fit. So, be there. Now, when you're giving in circulation, when you're putting IV axes and, taking blood and sorting magnesium sulfate, in real life, all this takes time. It's not something, it's very easy to go through it here, but it takes real time. And that's why we have pre-filled medications in the eclamptic box. Yeah, because imagine, I'm going to just go through, I'm just going to show you the doses a bit later, and then you will know how difficult it is to actually remember those doses, especially when, this lady is fitting, you have, maybe have a SHO or a GP trainee with you, you have less staffing on there. It's really, really, that's why it's important to make sure, familiarize yourself. Where is the eclamptic box in your labor ward? Where is it kept? Do you know? If you don't, please go tomorrow and have a look. Do you know where the MOH box is? Do you know where the anaphylactic shock box is? Please do that. These are little nuggets that are really, really important to keep in mind. And this is basically something that's in a tabulated form that just tells you, call for help. I've already said, support, airway, breathing, circulation, control seizures. Yeah. So once you've done ABC, control seizures, you'll give magnesium sulfate. It's usually 4 grams IV over 5 to 10 minutes. Then you'll give a loading, you'll do a maintenance of 1 gram for at least 24 hours. If she's having recurrent, then you'll give 2 to 4. We don't, don't give diazepam or thiopental or anything like that. And basically, this is pretty much what I've said, how much the regime. This is directly from the NICE guideline, the 2023 one. And one really important thing is, so let's say if this woman has delivered at 8 o'clock in the morning, and this fit is at 10 o'clock, yeah, in the morning, and you've started her magnesium sulfate, when do you think you'll stop the magnesium sulfate? From 8 o'clock next day or 10 o'clock next day? I think what's most important for you to remember is that it'll be 24 hours after birth or the last fit, whichever is later. Yeah? That is a really, really important point to take home. So, and you look out for the signs of magnesium toxicity. I touched on it before. It can occur if serum magnesium is more than 4. Infusion should be stopped, and we should check. We do hourly patellar reflexes to make sure that the lady doesn't lose her deep tendon reflexes, because that's one of the signs. Also, the respiratory rate is to be done, and oxygen saturation are to be done when she's on. What if you think, what happens now? This woman, you have another, you've sorted her, you have beautifully sorted her fit. Now you have another emergency buzzer and say, sorry, she stopped breathing. What you going to do? What you going to think? Oh, this is a woman. We're waiting for her creatinine. She's eclamptic. She's had a fit. We put a magnesium sulfate. She stopped breathing. What do we think it is? Yeah, you could think it's magnesium sulfate toxicity. Yeah, so give her calcium gluconate, which is an antidote. And what's the most important thing about calcium gluconate? Remember the 10 mL of calcium gluconate, 10% IV. Yeah. 2 10s. Remember that. We actually give it over 10 minutes, not 3 minutes. So it's 10, 10, 10. So, these little things you will not forget when you're actually in that. And labetalol hydrazine, I've written the dose. This is from the prompt. This is what we use in our guideline. But, you're not going to remember it. So make sure you familiarize where your eclamptic box is, because these will be there. Yeah. This is just a flow chart to, do what. If you have systolic blood pressure like this, so what you'll do is you'll make sure she's not asthmatic. If you're asthmatic, you'll go to nifedipine, and if the nifedipine doesn't work, you'll go to hydralazine. But if she's not, then you'll give her labetalol IV. Yeah, and this is the dose. You could go up to maximum of sort of 4 doses IV, and if that doesn't work, you'll start IV infusion. So when I was talking to you about investigation of this lady who was fitting, I talked to you about the bloods. I didn't talk about anything else, because that's not what you're going to do at that time. You'll just be doing that. You'll be managing her seizures, yeah? But once her eclampsia is sorted, you will be looking at doing a urine PCR, and you will, if later on she's symptomatic, you will have a radiological CT or MRI brain. And I'll come to in a minute as to why we do that. If she's still pregnant, you'll do a CTG. If her fits and everything is settled and stuff, I've written ultrasound scan there, but we tend to, depending on the gestation, usually when we start a magnesium sulfate drip, we tend to deliver them. Usually that's the usual, depending on the timing. So I have started somebody at 26 weeks and stopped once everything is settled, but that's not usual. Usual practice is you start and then you deliver. Now, the other thing I haven't mentioned is that what you have to do is you have to ensure that the blood pressure falls, there's no adverse effects to the woman or the baby if she's still, and you modify the treatment. So if she's not responding, or she's had recurrent, you could give her something, like I said, 2 to 4. If she's not responding to labetalol, you can give her hydralazine, but you have to preload her before. The other thing is that when you start on magnesium sulfate, you have to look at the fluid overload as well, because of Sue had talked about the permeability, the intravascular permeability. Intravascular oncotic pressure is quite low. The blood vessels are really permeable, so all the proteins go out, all the water goes out. So giving her lots and lots of water is not going to help her, because it's all going to come out. So you have to limit the fluid to 80 mL per hour. It could be 80-85, and unless she's got ongoing hemorrhage and things, and then you replace that. Now, steroids, you have to manage her if according to, again, what is a gestation. So if this lady is, 37, 38 weeks, 36, you don't have to think about steroids. If you're talking about somebody who's 32 plus 3 or something, you'll be thinking about that. Yeah. Mode of delivery, again, clinical circumstances and the woman's preference and the gestation. It'll be very difficult to offer somebody a normal vaginal delivery at 32 weeks if she's having repeated eclamptic fits. And postnatal is really important as well, what you're going to do. Some of the complications, placental abruption, preterm labor, blood clotting issues, HELP I've mentioned. Now, because of this permeability of the membranes everywhere in the brain, in the various organs, they can have pulmonary edema and they can be quite breathless. So it's important to keep an eye on that. PRES is actually sort of a brain condition. Is a posterior reversible encephalopathic syndrome, and they are not able to talk coherently. They can't see. They do lose some of the cognitive functions, and stroke. Yeah, stroke, stillbirth, and at the end, death. So these are the real complications. Now, it's a very, very quick overview of what we do postnatally because it's important. Now, you may not be in the hospital setting. You may be in the community, and you've got this lady who's come up with it. So make sure if it's this would already be done. We tend to anybody who's got eclamptic fit, we tend to discharge them about 4 or 5 days. So what is the practice in your hospital with an eclamptic fit?
No set practice, just home when the woman is stable and ready. So
Yes.
there's no set standard but I would say the median stay would be approximately 5 to 6 days. So first 24 hours on HDU because they still have to be on magnesium. The next 24 hours will be monitoring their general well-being, trying to normalize as much as possible, weaning off any intravenous antihypertensives. Then the next 2 to 3 days will be trying to make sure that they feel okay, bonding with baby, baby might be on NICU. They're happy with feeding before they go home. But I would agree for about 5 to 6 days.
Yeah. So we tend to we have a 5 days cutoff. We don't tend to, unless she's brilliant and really absolutely turns back to normal and she wants to go home, then yes, but usually it's 5 days with us. And we if it's a step down from critical care, severe, this is what you will do. You will measure the platelet counts, you'll do serum creatinine 48 to 72 hours after the step down, and repeat as clinically indicated. Yeah. And she can be transferred to community care when she's got no symptoms of preeclampsia. What's really important is every time you do the blood pressure, make sure you ask them, have you got severe headache? Have you got epigastric pain? Because they can have this. It's common at 48 hours after, but they can have it, a week or so as well. And the GP will check, we'll check them in 6 to 8 weeks' time. A choice of treatment, we usually give an elapril and monitor after they're settled. Additional treatment if it's required, and they can breastfeed. If they're preterm, we monitor the blood pressure and baby to make sure that the baby's fine. And this is actually directly taken from the NICE hypertensive guideline. You can have a look at it. I think I will just touch on one thing, which is women with any kind of hypertensive disorders in pregnancy, overall risk in the next time is 1 in 5. And that's it for me.